Hey, y'all. Thank you for being here. It's 8:35. When Laura and I saw that we were presenting at 8:35, we didn't think we would have anybody in the room. So look, it's a full room. My name's Ashley Varner. I'm a clinical social worker in the Emory Cognitive Neurology Clinic. I'm joined by my colleague, Laura Metters.
Good morning. I'm Laura Metters. I am also a clinical social worker. I work for Integrated Memory Care, which is a primary care clinic that only serves patients with a dementia diagnosis at Emory Healthcare.
And we feel really fortunate to be here this morning, so thank you. Thanks to the planning committee for inviting us, and thanks to y'all for being here. We're going to talk a little bit about how you can support your patients in their day-to-day lives, and the corollary to that, your patients with Alzheimer's disease and related illnesses, but also I think a corollary to that is what can we put in place so that your MyChart or your Cerner portal doesn't fill up with messages from caregivers who are absolutely exhausted. So we'll go ahead and get started. Our objectives this morning are to understand more about patients and their families, and what they need besides medical care. Right, because they come to primary care for everything, right? You are the ones that solve every problem that they have. We want to explore how to make really effective referrals so that you're not having to make them again and again and eat up that time. We want to learn, I'm going to talk a little bit about what Georgia MemoryNet does and the MACs do to get that process started for you and how you can dovetail with that process. And then we want to just talk a little bit about how really effective referrals affect quality of life for our patients, our care partners, and also our quality of life, y'all's quality of life.
Thank you, Ashley. I want to start this presentation. We're going to talk about a lot of things, but I want to sort of start with this high level of what happens when a patient gets a diagnosis of a type of dementia. This is not a diagnosis that affects just the patient primarily. This impacts their spouse. This impacts their children. This impacts their siblings. This impacts their network of friends within the community, what they are able to do. So a diagnosis of dementia is really changes a lot of things for a lot of people. And accepting those losses that come with it is something that not just the patient living with the disease has to do, but it really is something that the whole family system is adjusting to and adapting to. And so that makes treating these patients and helping these patient and family systems really challenging. Dementia is something that changes the nature of all of these relationships as well, right? Nobody wakes up and says, I can't wait to be a caregiver today. I cannot wait to wipe my husband's bottom when he can't do this anymore. Nobody wakes up and says, I can't wait to fight with my dad over taking a bath every day. Caregivers come to this job, and it really is a job of providing care for people living with dementia at some point as the disease progresses. People come to this job because of the relationship that they have with their loved one, right? Because this is my dad, because this is my husband, because this is my mom or my sister, I am going to do this work. But it's often a job that people have not planned for, right? They have not trained for. They don't have training in how to be a caregiver typically. And even if they do, it's an entirely different ballgame when it is my spouse, when it is my dad, when it is my mom, because I have just a different relationship. It's not a professional relationship anymore. It's a very personal relationship. And so dementia is really changing that entire family system for a lot of people. And so it's important to remember that when we're giving that diagnosis, and it's important to make those considerations when you're hearing families who are coming in and sharing their concerns. What are some other things that we know about caregivers? What else do we know about caregivers? So we know that caregivers are overwhelmingly female, and as the mother of an only son, that's a little bit bothersome or worrisome for me. So yeah, Kalisha's with me on that one. We know that it's overwhelmingly female. It's particularly in non-white populations. It's often those daughters who are providing care for the person who is living with dementia. We know that in non-white populations, there's often a higher prevalence of a dementia diagnosis than there are in white populations. And we also know that non-white caregivers are less likely to use some of those formal resources that are available in the community. And there's maybe a lot of reasons for that. We also know that many caregivers are providing this care they have annual household incomes of $50,000 or less, so that's not a whole lot of money to hire these additional community resources. In the Atlanta community, we have a large population with a lot of different community groups and ethnicities, but I don't know of a Korean assisted living that is serving culturally appropriate food. So are you able to access services that look like you? Are you able to access services that you feel you can relate to? So that's a challenge for a lot of caregivers as well. We also know that caregivers for people living with dementia are under a considerable more, they're at higher risk for some depression. They're at higher risk for other sort of mood disorders. We also know that they are at higher risk for isolation. So as their job becomes more all-encompassing on providing care for the person who is living with the disease, not only is the patient's world getting smaller, but that family caregiver's world is getting smaller because they are less likely to be engaging in activities that they find meaningful. They're less likely to be engaging in their support groups and their support networks. And they're less likely to be seeking care for themselves as well. So they may not be seeing you as their primary care provider because they are taking care of that person and they're making sure they get to all of their appointments. But who would provide care for mom, dad, or spouse if they were to go to their primary care provider? And so that's a real trade-off that families are negotiating when they are there as caregivers. Family caregivers are a critical part of the care team for us as primary care providers. It's difficult, speaking personally, Emory has just gone through a medical record change to even figure out who caregivers are sometimes in the chart, right? The systems don't always do a good job of identifying that for us, but they are such a crucial and critical piece of the treatment plan when you are talking about people living with dementia, right? They can be a really reliable historian. You ask your patient, how are you doing? Are you having any trouble with anything? No, I'm great, everything's fine. I don't know what you're talking about. Your daughter mentioned these concerns? Nope, I don't have that, right? And so to be able to have a historian to compare this information to can be really helpful when you are trying to figure out what the problem is, what's really going on with this patient. They can be really key to your treatment interventions, right? For all of the medications that we have out there, and we have some exciting ones that are coming up, the family caregiver is still the most effective treatment intervention that we have, right? And it affects knowing what the family caregiver is able to do really in our practice determines a lot about what treatment recommendations we're going to make. We may not recommend insulin if the patient is managing medications by themselves and can't remember if they've given it to themselves already, have they not given it to themselves? So is somebody there to help with that medication management, or is the patient doing this all on their own? You can have, that really impacts a lot of our treatment decisions to know how involved is that family caregiver in the patient's sort of day-to-day management. They're also a critical piece to the patient being able to continue to live in the community, right? So they may be able to live independently for a long time, but they need some support. They need those people to provide reminders for bathing. They need reminders to eat that day. They may need a family member to set up automatic bill pay so that they're not defaulting on the gas and electricity and then things are being shut off, which is really, to get the heat or the AC turned off is really critical and has some significant consequences in South Georgia. And again, like I talked about, it's not a job that most families have had the training to do. This is not something that they sign up for, and it is really overwhelming to try to learn all of these different things that they are having to compensate for as the person is experiencing these different losses. So family caregivers need a lot of help, right? They need a lot of resources in the community. This is a short list of things that people may need to access when they get a dementia diagnosis, but it doesn't mean that they will all need these things, and it doesn't mean that they will all need these things all at the same time. So as the symptoms change, as the family system changes, they're going to need to access different types of resources. And so you can see a ton of things here. And if you're being overwhelmed about like, well, I don't know where these things are in my community, we'll talk a little bit about resources that maybe you may be able to connect to, because it is not something that I expect the primary care provider to be the expert on all of these things, but it is helpful to have an understanding of what resources are available in your community and what those different agencies and organizations can do and what they can't do. I think we know that there are benefits to connecting families to these resources in the community, right? We know that families can really benefit from these different things. We know that it gives people time to plan, right? And so even if the patient is past the point of being able to make legal arrangements for themselves, if I find out that my husband has dementia, then I'm probably going to change my documents to say, I do not want you to be my decision maker anymore. I'm going to appoint somebody else to do that on your behalf. So it may give family members some time to better prepare for their own situation, even if the person is past that point of executing documents themselves. It allows caregivers to sort of acknowledge and name what is going on, right? So that helps them hopefully be able to seek appropriate support and connections in the community. Hopefully that is caregiver respite. That can come in lots of different forms. Sometimes that's just asking for help, asking other people to help out with the needs that they have. Sometimes it's accessing the formal resources in adult day programs or assisted living placement, other home care that may be brought in. But having that diagnosis can help people understand what type of support that they need and to be able to access that respite. Hopefully with some education about what this diagnosis is and what this diagnosis means, there may be opportunities to avoid sort of unnecessary healthcare encounters. And I have had patients who, before they came to us, Mom didn't recognize who I was today. How can she not recognize me? I'm her daughter. This must be something critically wrong with her, because how could this happen? And we would have said, well, no, of course, this is a normal part of the disease progression. We expect this. But she didn't know to expect this. This was a new revelation for her. So if she's got some education, some opportunity to provide some support, to attend support groups and engage with those community resources, you may be able to avoid some of those, what we would consider to be avoidable hospital admissions. And hopefully, if you have support, if you've been able to engage in these community resources, you've named the disease and sort of have gotten help along the way, we're able to avoid or delay that institutional placement in a skilled nursing facility as well. This may not happen, but I think these are some of the benefits that we're really hoping for by being able to connect families to community resources. A skilled nursing placement is not necessarily a bad thing if that's the appropriate place, but delaying that can be really helpful for a lot of families because it is so expensive. And for many families, that is sort of the worst case scenario, right? I told Mom I would never put her in a home, and now you're faced with, but now she needs to go to a skilled nursing facility. And so how can we avoid that for as long as possible for people? Connecting patients to community resources is really difficult for a lot of reasons, right? And part of why it's really difficult is because every family is different. Every family system is really different, and every family's goal is really different. So I've worked with some families where it is a really successful day because we placed Mom in what we thought was the best skilled nursing facility in Atlanta that they could find and be accepted into. And that was a red letter day. They were so excited that this happened. I've worked with other families where that would have been the absolute worst day of their life, where they had to place Mom. So every family's goals are different, which makes it really difficult to sort of make a blanket treatment statement of here's how you're going to get through this disease with these resources, because everybody wants different things in this disease process. And so it really is about how do you talk with families about what they want? How do we connect them with the resources that are going to help them get that? It's really tricky. Family dynamics are also really tricky, right? So you've got the one daughter that you're talking to that has one plan, and then the other daughter has a totally different plan, and they are not talking to each other, and they are not in agreement. I hear y'all sounds like y'all have some of those too. So that can be really tricky to navigate and know how to provide that support. I think they also have an expectation, a lot of patients and families, that you know everything, right? And you can, if it is available, you will connect them. And we had a patient just this week who said, well, mom has dementia. We needed all of these things. Why didn't you give me the psych referral? Why didn't you do these things? And we're like, well, we didn't think she had any psych problems. Like, you aren't telling us these things. And so I think patients sometimes have an expectation that you're a mind reader and that these things are just easy and that you should be able to solve all of the problems, which we know is not, I'm your primary care provider, not an omniscient wish giver. And so that is a challenge in navigating a lot of patient and family encounters as well. And so I think your job is not necessarily to be able to know all of the things and do all of the things, but being able to connect families with the resources that are going to be able to help them at the right time is really helpful. And so why doesn't that happen more frequently? And I think part of it is time, right? Part of it is the visits are short. You are trying to do this it's hard for us to do it in our clinic, and we have 40 minutes and a social worker full-time on our team, and it's still difficult for us to do. So when you have less resources and time and staffing, it is incredibly challenging. I think it is something that needs to be a system needs to be in place for who is doing this. It is not necessarily the physician's responsibility. They may not be the best person to be making these referrals, but is there a system in place so families can get this support? Is it that there is a medical assistant who can help with the referrals? Is there an office manager who's going to help keep the list of community resources? There's lots of different ways to sort of help make sure that families have this support and have this information and access, but it doesn't happen haphazardly. It doesn't happen casually. It needs to be something that happens really intentionally. And so thinking through your clinic and your resources, who are the best people who have the bandwidth to do this, or maybe the natural inclination to provide that support as well. And then what makes a good community referral, right? This is really tricky, I think, for a lot of people to figure out what resources are available in the community, and that is something that is ever changing. As grant funds are changing, the resources, the programs that are available, and the requirements for how to access these programs are constantly changing. This happens, I think, across the system because a lot of these nonprofits get a donation, they get a grant, they're able to provide these things, and then suddenly they're not. And so helping families navigate that can be really tricky, and constantly keeping that list updated, I think, is really difficult for providers who are trying to take care of lots of other things in their day as well. But it's important to have a general knowledge base of what's out there, as well as who pays. And newsflash, Medicare does not pay for everything, right? Medicare is not paying for assisted living. They are not paying for 24/7 home care. They're not paying for every day your person to go to an adult day program, even though we would consider it is a necessity because this person cannot stay at home alone because of the disease process. That Medicare sees things differently. I think with the implementation of GUIDE and that new alternate payment model, there is an emphasis on, or at least a recognition that these community services are really important. And there is an annual amount that families can receive or patients can receive to assist with respite, but it is a drop in the bucket compared to what families need for this ongoing yearly care. And so there is at least an acknowledgement that these additional services are important, but Medicare is not the payer source for it. And so I've had to deliver lots of bad news that this is not free care. We don't have this available to you. And so I think providers can help by setting expectations of just saying, this is private pay. There may be some available resources in the community, but sort of couching this as letting them know that there may be fees that they have to pay, that this is not 24/7 care, and that sometimes the options are not good. It's about picking the least bad option out there for the families. I think knowing the entry points for what is available in the community is really important. Ashley's going to talk about how Georgia MemoryNet can help with that, but knowing what does your AAA offer? Do you even know that your county has an area agency on aging, and who would you contact if you wanted to refer a person to that who may or may not be a part of the Georgia MemoryNet system? And then you may be sending all these referrals back, but are you getting any information back from families or from the organizations about what's happening? Families are often my best referral source, right? They come back and tell me, yeah, this place is amazing, you should send everybody here. Or they come back and tell me, this place is terrible, don't send your dog here. And so it's really helpful to figure that out. And the other piece that's tricky, at least in the Atlanta market, is that this is changing all of the time. So the great community last month is a terrible community this month because they've been bought, the administrator has left, staffing turnover has happened. So this is a constantly changing system to stay on top of, which can be really difficult for everybody to be able to make those good connections for patients and families. There are a few things in talking about setting up expectations and referrals. This is just my personal social work soapbox about what are the differences between these two, or between these different things. I think we are really guilty of using home care and home health interchangeably. We're really guilty of sometimes using these terms interchangeably with some pretty significant consequences to patients and families and what their understanding is and what their expectations are. The first one is the difference between assisted living, skilled nursing, and memory care. These are not all the same thing. I once had a patient who was admitted into the hospital. This was before my time with Emory. I was working as a care manager, but she had come from an assisted living, had gone to the hospital, and the hospitalist had written, go back to her skilled nursing facility, but she wasn't living at a skilled nursing facility. And the assisted living said, well, the hospitalist said she had to go to a skilled nursing facility. We can't meet her needs. And so we spent days and days with this woman in the hospital trying to advocate for her to go back to her assisted living, which is where the hospitalist intended her to be anyway. But because they didn't understand the differences in what that is, it was a really big fight. And so the assisted living is essentially a real estate agreement with some additional services that they're providing, usually 3 meals a day, some medication administration, but they're not providing skilled needs. That skilled nursing facility, there are nurses on staff, they can take orders, there is a medical director. It's one of the highest levels of care you can receive outside of a hospital. And so if you need hands-on assistance, this is really a much more appropriate setting for a lot of patients and families. Memory care can be in either assisted living or skilled nursing facility. It typically just means that the area is locked so that residents can't accidentally wander out. The differences between home care and home health, this is really confusing. We've had lots of conversations with family members about how, oh, my insurance will pay for home care. Well, home care is traditionally a private pay service that has sometimes caregivers, sometimes just companions who will come out to your house for a shift and cover to make sure that the person is supervised, to make sure that they are potentially assist with some ADLs and getting them dressed, getting them bathed. They're probably not assisting with medication management unless you're additionally paying for a registered nurse to come out. So that's home care, but it's an out-of-pocket expense, which in the Atlanta market is about $25 an hour, and insurance does not cover that in most cases. And then there is home health, which requires the physician's order for physical therapy, occupational therapy, speech therapy, and that is very different than the home care, which is a shift where people are expecting some assistance in providing care for mom or dad. And then the difference between an elder law and a state attorney, this can be really important when families are faced with making choices and advanced planning. An elder law attorney is really excellent at knowing how to arrange legal documents for when a person is still living and may need to access different community support and resources. How do we protect those assets so that we can pay for care? And a state law attorney is really good at how do we protect assets after you have passed away. And so for most of our patients, what they really need is a good elder law attorney who can help them navigate options and care resources while they're still alive. So I'm going to turn this over to Ashley. I know this is probably overwhelming. I see some of y'all that look like a little wide-eyed. Ashley's going to talk more specifically about how Georgia MemoryNet can help with connecting families to resources.
Thanks, Laura. So recognizing that these community referrals are kind of a key piece of quality of life and an effective referral back to the PCP, we have a process. This is sort of a busy slide. It was even busier before, so thanks for your patience. But that referral from the PCP, Georgia MemoryNet has a 2-visit process. And the first visit, we have something called community service educators. They meet with the caregiver during the first visit while the patient is undergoing neuropsychological testing. So the neurologist meets with, or the provider meets with the patient and the caregiver together. The patient then goes and has neuropsych testing. The community service educator meets with the caregiver and identifies what that family's needs are. From there, the patient goes on for imaging and maybe some lab work in between appointments, and then there's a second appointment where they come back and receive a diagnosis. And at that point, we give patients a care plan, and that care plan also comes back. And with that care plan, a referral is made by the Memory Access Clinic to the Area Agency on Aging, and specifically the Aging and Disability Resource Center, and to the Alzheimer's Association. Okay, so we've already primed the pump. From there, you can see on the second 2 lines that the Area Agency on Aging, the ADRC worker, reaches out to that family. So we've changed it from a pull mechanism where they have to reach out to the ADRC to actually receiving a phone call. An assessment is done if they reach the caregiver or the patient, depending on where the patient is in their disease process. And then the process is begun to provide whatever resources that family needs. Also, the Alzheimer's Association sends a packet of information to the patient and caregiver, and then reaches out within the next week or so. The challenge of this, right, so you're set up, and this is a wonderful place for y'all when folks call and say, how do I get home care in place to refer back to the ADRC for assistance of what's available in the community? The challenge is that care plan is a snapshot in time, right? That care plan is what that patient and family need on whatever today is, but next year they're going to need something different. So continuing to refer them back. So what is the ADRC? And Courtney showed some of these same slides, or versions of these same slides yesterday morning. So maybe they'll stick this time because you've had a whole lot of foundation set. But thank you for priming the pump, Courtney. So the Aging and Disability Resource Connection is a Georgia statewide program that's run by the Area Agencies on Aging. It serves as a no wrong door entry point to supports and services that are available from the state. It's meant to be a coordinated system, and I failed to mention that after we make that referral, the ADRC worker and the Alzheimer's Association report back to us, so we know that that's been we closed the loop, and we know, was this caregiver open to receiving information about services, or were they so overwhelmed that we need to make that referral again a little bit down the road, or they may be being referred again by y'all. A little bit of information about how to make that referral. There are, how many, Courtney? 13, 12? 12 areas on Area Agency on Aging. If you don't know where yours is, we have some flyers here. This will also be online. You can copy these out. Even the idea is that if you want to have them available in your practice or load them up, patients can find their Area Agency on Aging. I'll put it on the table. Thanks, Courtney. On the back is the advocacy organizations. So this is a really easy flyer to be able to give patients who are in your office, make it available to them. And all of the Area Agency on Aging sites have slightly different they have a core set of services that they provide, and then they also have additional services. It's a really wonderful place to be able to refer to because they have somebody who is assigned to keep up with all of these resources. So as Laura mentioned, it is more than a full-time job to keep up with which nonprofit, which hyper-local organization that serves a 4-block city, a 4-block area, but just a 4-block area, but they have incredible resources. They'll come in and remodel your house, but keeping up with that is nearly impossible. That is what the ADRC helps with, and they have these core services, so personal care assistance, and we'll talk a little bit more about this. Transportation, which is huge, especially in rural areas, right? And also some of the congregate meals, some of those services that may or may not be available to folks depending on what they're, other than through the ADRC. Also, just of note, they do have the Elderly Legal Assistance Program. So for your clients who say, great, you want me to go see an estate attorney, or you want me to, how in the world am I going to possibly afford that? The Elderly Legal Assistance Program is a wonderful resource to be able to get directed and get help. So the ADRC can provide home and community-based services. These are non-Medicaid services, so this is through the Older Americans Act. So we were talking earlier about the fact that Medicare doesn't pay for home care, right? These are much sought after, so there is generally a waiting list, but it is out there, and we want to get these folks on the waiting list, right? Because if they need it now with this diagnosis, they're going to really need it in a year. All that's required is that you must be 60 years of age. Anyone, even those with early onset who are in their 40s, early onset Alzheimer's disease, can qualify, and it provides a number of different in-home services, which you can see there. The Elderly and Disabled Waiver Program provides some similar services, but it does have a qualification. It's a Medicaid waiver program. It has a slightly higher means testing than what I traditionally think of as straight Medicaid. But it also, the whole goal of, we call it EDWP, is to keep people out of skilled nursing facilities, right? That is why the state developed this program, is to keep people in the home out of skilled nursing facilities. And they have a fair amount of flexibility to provide services that will enable folks to stay out of skilled nursing facilities. There is a means test, though. If you have $1 zillion in the bank, you're not going to qualify for EDWP. You may also, I put this slide in because you may also have clients who come in, or patients who come and ask you about, I heard that I could get paid for providing care to my mom. Anybody had that question come up? Yeah, I thought maybe so. So that is through the EDWP program. So the first step to that whole process is to apply for EDWP. It will not pay spouses to provide care. That's important. They don't even have to go down that path. Yeah. Can patients be fast-tracked? So that's a great question. The question is, can patients be fast-tracked into these programs? The EDWP waitlist works off of a mixture of first come, first serve, and level of acuity. So if somebody, I've seen somebody receive EDWP services in a 2-week time span because they literally were on the street. But when they are interviewed by the case manager, a lot of families, hot tip, a lot of families will say something to the effect of, I will never put my mother in a nursing home. That is not going to happen. And from the case manager's point of view, the goal of this program is to keep people out of nursing homes. So that tends to move people down the acuity list, right? Being really clear about what's going to happen. Being really clear about what's going to happen is, if the service doesn't happen, is important. There are assistive technologies that can come through the ADRCs. The Alzheimer's Association, importantly, has a 24/7 helpline for caregivers. So when that caregiver hits the wall at 3 o'clock in the morning because their loved one is up, they're both short on sleep. We hear this all the time, right? And just doesn't know what to do. This is a wonderful resource for them to know about, because otherwise, what happens? I call 911 because I don't know what else to do. And then we start through the whole emergency room process. They also have support groups, some of the things that you're familiar with. They do in the Atlanta area and are spreading through the state, or trying to spread through the state, programs for folks with mild cognitive impairment. Some really musings at the High Museum and some other interesting things. And they do have virtual care consultation with trained social workers through their office in Chicago. So for those families that you spend a lot of time on because the two sisters can't agree, or the second wife and the adult children can't agree, that's what I see a lot. I'm just telling you what I see. Those virtual care consultations can be really useful. We offer now through GMN the Savvy Caregiver program. This is a skill building program for caregivers. We offer it virtually. Laura is one of the ones that helped develop it. It is evidence-based. It's been around for quite a while now. And there are flyers out there. We offer it for free across the state, so let your caregivers know about it. It is incredibly, the words I hear from the caregivers that I teach in this program are game changer, life altering. It does a lot of education and a lot of teaching folks how to intervene effectively as a caregiver and avoid those crises. And then a few other resources. I was thinking last night about things that eat up time and folks, caregivers who are suicidal or who are feeling like, I just don't know what to do. I don't know if y'all have run into that. I know I certainly have. There is a suicide and crisis hotline now that's 988. It's manned 24/7. Domestic violence, those relationships where there was domestic violence before there was ever any part of dementia can be really challenging. That National Domestic Violence Hotline, and then the Everyone Project, which Ted mentioned, Dr. Johnson mentioned yesterday. So, quick. I think we're done.
Yeah, I think we're done.
Do we have time for any quick questions? All right.
Are those slides available?
We can make them available.
We're going to put all the slides that aren't already loaded in Google. We're going to collect the slides as they were presented here, and we'll upload them to Google over the next couple of days. So thanks for those questions.
Do these programs work in coordination with like patients who are placed in hospice programs, or is that eliminating?
Who are enrolled in hospice program?
Like if hospice is something the family is considering, do they still have these other available resources?
They do dovetail with, but you can't double dip. So if you're receiving a home care worker from EDWP, then you wouldn't have the home aid part of the hospice program. But you could still get the other parts of the hospice program.
Okay.
Was that clear? I hope so.
Yeah. Yes.
You have to be a citizen to qualify for this program.
The different ones are different way. Different ones have different requirements. Yeah, it gets really complicated, so I'm not going to go down that path. But it's a great question. You do have to be a resident of the state of Georgia for all of them. Isn't that right?
Yeah.
All right. Thanks, y'all. These will be out, if you could take a stack of them back, and we'll also put this online. It may be helpful just to be able to shoot it to patients, and there'll be live links that they can click on.